Well, good afternoon, everybody, and welcome. I'm delighted to have you all with us today. I'm Sandra Hernandez, and I'm the President and CEO at the California Healthcare Foundation. This topic of health data exchange in California is one that the state has been making great progress on, and so our goal today is for you to hear from a very distinguished panel about what they're doing, how they're doing it, how we might scale it, and so I'm very excited. For those of you who don't know the California Healthcare Foundation, we're an independent philanthropy. We really work to try to improve healthcare from a systems point of view for all of California's, but also with a very specific focus on low-income communities to make sure that folks who have the greatest barriers to care really take advantage and are benefited from all the systems work that we're doing. Today's convening is one of a series of briefings that we sponsor for the Sacramento policy community. These briefings are really designed to bring you relevant healthcare issues, to bring you data, to bring you trends, and really importantly, to help us think together about possible solutions to some of the challenges that we know we face in the state of California. The topic of data exchange is professional. CHF has done a tremendous amount of work. It's also very deeply personal to me. And with that, I'll share just a brief story. Many years ago when I was practicing primary care physician during the heart of the HIV epidemic, I had a patient who I had taken care of for many years with HIV disease. He was Latino, he was monolingual Spanish speaking, and he developed an AIDS-related malignancy. He was being very carefully coordinated and managed between me as a primary care, his primary care physician, and the oncologist at San Francisco General Hospital. And that was going reasonably well. That system is all one system at that clinic at that time. I saw him on a Friday afternoon in a routine visit. His white count was lowish. He lived in a makeshift studio apartment in the Mission, which was really a garage that had been converted to a livable space. He lived alone. And when I saw him on Friday afternoon, I looked at his white count. It was lowish, but not horrible. He was afebrile, looked pretty good. He had an oncology appointment for Monday morning, and I was going to see him the following Friday. And my instructions to him were, if you develop a fever for any reason over the weekend, do not pass go, come directly to the emergency room, where, of course, hopefully my note from Friday would be found. On Monday, he didn't show up for his oncology clinic, and on Friday, he didn't show up to his primary care clinic, and asked the social worker to go find out what happened, and it turned out that on Saturday night, San Francisco General Hospital went on diversion, and he called an ambulance. The ambulance took him to another hospital, and he passed out, died of sepsis in that emergency room. Because I happened to have been the director of health, I actually saw his death certificate, which didn't say anything about HIV disease, didn't say anything about his lymphoma. It was really a patient who came in and died of sepsis in the ER. And I tell you that story in large part because, to me, it really weaves what it is we're trying to solve with data exchange, right? We want to be able to make sure that any clinician at any point of care has timely, accurate, thorough information about that patient, even if they themselves, and often they can't, describe what chemo they're on or what HIV medications they're on. The way the system works now is fragmented, it's siloed, and really we put the burden so much on the patients to be able to transport the information from this clinic, from my medication list, from my oncologist. And so for me, the take-home message here is social determinants of health matter, timely data matters, health equity matters. And so data exchange, in spite of the fact that it's a highly technical some would even describe it as a geeky issue, and there are a lot of technical issues. The reason it matters to do it is to make sure that the many patients like this patient, and by the way, we don't count them, we don't have a way to count them, but many, many, many patients have endured just that kind of phenomenon. And so it is, to me, just a real pleasure to today to look at the exciting things that California has started to do. And there has been a lot of momentum. We're really trying to build a future where patient information moves securely and between doctors and health plans and care teams. And we're at an important juncture, right? The data exchange framework, which was launched in 2021, really was a historic undertaking. There are now 450 odd healthcare organizations across the state that have signed on to the framework. And California Healthcare Foundation has really been proud to try to bring information from other states to understand what's worked, what hasn't, as a real way to improve outcomes, to get better health equity, and really to fill in what are these now silos and gaps in our delivery system. But of course, there's more work to do. Successful health information exchange depends on strong leadership, and it really fundamentally also relies on public trust. And that means really governing with a sense of oversight that really commits itself to transparency, to accountability, and of course to data security. So some of you may know that, I don't know, 2 or so weeks ago, the great team that has been working on data exchange now for several years moved over to the Healthcare Access and Information Department, HCI, and quite appropriately so, because data exchange really is about access and information. And we're quite fortunate because, leadership does matter, and Scott Christman has been working on this issue since before 2001 and before the framework. He served as the Chief Data Officer for the California Department of Public Health. He has tremendous experience overseeing health data programs and IT services. He used to be at the precursor to HCI at OSHPD, I know Scott. And so in the spirit of really having dedicated leadership over a long period of time with technologists as well as clinicians, really it's my deep pleasure to welcome Scott to share a few remarks about how he thinks about HCI taking on this new responsibility. So Scott, welcome. Thank you.
Great. Thank you, Dr. Hernandez. We appreciate the support. Always appreciate the partnership with the California Healthcare Foundation over many, many years, and many initiatives. And this is the same. So again, my name is Scott Christman. I'm the Chief Deputy Director for the Department of Healthcare Access and Information. HCI is our handle now. And yes, we used to be OSHPD for a bunch of years and are proud of the work we do as a health data organization. So we're excited about the transition I'll touch on. I'm standing in actually for our director, Elizabeth Landsberg, who regrets she's not able to join us today, but I'm glad to be here. I'm excited to see actually a lot of friends and colleagues from many, many years of efforts in this area. And again, thank you, Dr. Hernandez, and to CHCF for sponsoring this important discussion around data exchange in California. As we do transition the Cal HHS data exchange framework to HCI, it does feel professionally for me like a full circle moment. Dr. Hernandez mentioned, I took a job more than a decade ago with the Health and Human Services Agency to work on the state HIE program at the time. You might recall it was funded by high-tech grants. And I was quickly part of a team that actually worked to unwind Cal eConnect. And that was quite a learning experience. We ended up spending down the rest of the stimulus funds through local grants to health information exchange organizations. Actually, many or most of those are still going concerns, which is good to see. So I think something came out of that. But at that point in time, there was uncertainty around the state's position on health information exchange. But as Dr. Hernandez noted, the passage of AB 133 in 2021, the creation of the data exchange framework, that uncertainty was resolved in my mind. And we have a clear commitment to HIE, to data exchange here in the state of California. Now I'm excited, and we're excited as a department to transition this important work and the data exchange team into our department. The transition work has started. As mentioned in the last couple of weeks, we're actively integrating the DXF work and the team into HCI's broader program portfolio, really with our shared vision of a healthier California where all receive equitable and affordable and quality health care, regardless of where you are. Data exchange between healthcare providers, as we all know, is critical to an affordable, an equitable, quality healthcare system, improving coordination of care across communities, reducing inefficient administrative functions, and advancing more cost-effective healthcare delivery broadly. We're committed to supporting whole person care, and we embrace the vision for data exchange in sharing health and key social services information in communities across this great state. We very much believe that there are some meaningful synergies between the data exchange framework and HCI's existing portfolio, including our long experience managing patient level data, managing health facility data and information, and of course the emerging work with our Office of Healthcare Affordability, served by a tremendous board governing that work. And again, as I mentioned, we've all long considered ourselves a health data organization within state government, and we feel like the DXF is an ideal fit, and we welcome them into the fold. So HCI is ramping up. We're learning very much right now from the incoming staff and many stakeholders. We've had a bunch of conversations. We're going to have many more about the DXF program. You know, what's been most effective during implementation, and of course, what are the opportunities that there may be to help us accelerate the impact of data exchange across California, recognizing the need to improve both what information we share and how we share that information to reduce costs and improve outcomes for all people. We've already launched a listening tour. That's how we wanted to start, to hear from all of you. Actually, we have a team here from Freed Associates that's joined us right in the corner here today, ready to get your input. We want to hear from each and every one of you. Please do share with us, and that's really important. There's a QR code that you can use to offer input. Please stop by. We're going to synthesize what we hear from the stakeholders in the next several months to inform go-ahead plans beginning in 2026. So I am mostly here today to listen to all of you with much appreciation as partners in this work to make the very most of data exchange here in California. And again, just thank you to Dr. Hernandez and the California Healthcare Foundation for having us. We look forward to working together going forward. Thank you.
And I know that some of you may want to have questions for Scott, and so he's going to stay and join us here for the rest of the briefing and take any questions that might come up in Q&A. So now what I'd like to do is invite the panel to come up, and while they're doing that, I'll just briefly review their bios. Appreciate your leadership, Scott, and look forward to working with you in partnership as we have done for so long. You know, realizing the whole potential of hate data exchange is going to require state agencies, health systems, researchers, and frontline providers. It really is a system-wide transformation effort. And so I'm super excited to welcome this esteemed panel. They each bring very real-world experiences on the ground on this conversation. And again, we will make sure that we have time for Q&A at the end. Joining us on my immediate right is Dr. Julia Adler-Milstein. She's the founding chief of the UCSF Division of Clinical Informatics and Digital Transformation and a professor of medicine. She's one of the nation's foremost experts at the intersection of health policy and health informatics. She's authored more than 250 influential peer-reviewed articles and advises federal agencies, including the U.S. Department of Health and Human Services and Congress. She's been recognized through numerous honors, including being inducted to the National Academy of Medicine in 2019. Also with us in the middle is Dr. Tarek Madhi. He's president of Riverside Family Physicians and a board member of Inland Empire's Health Information Exchange, where he guides regional efforts in health data sharing and coordinated care. He's a respected healthcare leader with expertise in primary care, hospice, and palliative medicine. He's deeply committed to population health management, behavioral health integration, and continuous quality improvement. In short, he's advancing systems of care that are data-driven and patient-centered. We also have with us today Julia McConaughey. She's a senior vice president and chief of operating officer of Coordinated Regional Care Group, a division of Prospect Medical Holding, a network of hospitals, clinics, and physicians that provide high-quality and cost-effective care to diverse communities in Los Angeles. She oversees $656 million in hospital revenue and oversees 135,000 Medi-Cal lives, driving integration and value-based outcome through data-informed strategies. She brings a unique cross-sector perspective on health information exchange and its transformative role in population health. She has spearheaded implementation of chronic care protocols and social determinants of health screening tools that reduce avoidable admissions and really optimize data flow between care teams, impacting both cost and quality within a very high-risk population. So with that, what I'd like to do is start by asking each of our panelists. Hello, can you still hear me? Good. Each of our panelists, maybe this, Julia, I'll start with you, just to talk a little bit about what you see from the research and the data around how data exchange can help us address cost issues as well as quality issues. So Julia, I'll start with you.
Yeah, absolutely. Thank you for the opportunity to be here today. I love talking about HIE and interoperability. It's sort of a joke, but it does never get old because the challenges and the needs keep changing. So yeah, from the, I'd say, perspective of the research, I think a couple things have become clear. I mean, one is that we really do have to solve the workflow challenges and that we can do a huge amount of governance and policy work and get the data so close to the front lines of care. But at the end of the day, if you don't get that last mile piece right, it's just too much friction. And we have, frontline clinicians who are too busy, frankly, to figure out, okay, I have to log into a different system, or I have, thousands of pages that I have access to, but I don't have the time to go through them. So that last mile workflow piece keeps coming up, I think, as one of the top barriers. Where we then look at questions of cost and quality, I think the evidence is pretty clear that there are real cost savings from reductions in duplicative care. And that's, again, it's good for the healthcare system, it's good for patients, and that's one of the clear benefits. But there's also some nuances to the data. So for example, if we take the case of the story you shared, right, if information exchange had worked right and that individual had perhaps, an expensive hospitalization and then gone on to live many years, right? It's tricky. Sometimes bringing more information will actually increase healthcare costs. And so I just think as we have these conversations, we have to recognize that it could lead to higher quality care, which in some cases might be more expensive care, but in other cases not. And so if you look in the literature, you'll find many studies that show that HIE reduces the likelihood of a hospitalization if we get it to the right person at the right time. And then there's many studies that show that it increases the likelihood of getting hospitalized because there's more information to really understand the complexity of a given individual. So I think the cost-quality relationship is, you sort of see the full spectrum.
Great. Tarek, I wonder, you have been in the exchange in Inland Empire for some time as a clinician, as a family practitioner. I wonder if you'd share a little bit about how that system has helped you manage in your patient population, how you think about population health from the experiences in Riverside.
Well, thank you for allowing me to come.
Welcome.
I'm really excited to talk. I'm a primary care physician. I'm a family physician in Riverside, small group. We're 13. We have physicians in our group. We have 13 community health workers, 5 social workers, and a chaplain actually works with us in our practice. Let me tell you a story, and maybe that will explain how our HIE has really helped us a lot. But it also has been cumbersome in many ways. I had a patient about 2 weeks ago who got discharged, and then I got alerted that he just got discharged from the hospital yesterday, the day when I called him. Our nurses every morning will log into Manifest and look at every discharge from the hospital and try to gather information. And believe it or not, it does take a lot of time from them to gather all the information. And it's really important, the type of information coming. So this gentleman, he's an 81-year-old, and so I call him up and I say, "Hi, Mr. Smith, how are you doing today? I know you got out of the hospital yesterday. It looks like you had severe nosebleeds." And they admitted him. I'm not sure why, but apparently his blood count had dropped. And he said, "Oh, I'm doing great now, and everything's good." And I had about 70-plus pages of a discharge summary from the hospital that took me forever trying to figure out what was going on with him. But at the end, it says, "The patient needs to be seen by an ear, nose, and throat specialist." And I say, "Great," and I said, "We'll get some blood work on you, and just to make sure your blood count's up." And the next day, I get the lab back, and his liver enzymes are through the roof. So I call him up, and I said, "Do you have any other concerns, any abdominal pain?" I thought maybe his gallbladder. He said, "Well, they did mention that I had something on my pancreas." Great. I went through the discharge summary. There was nothing there. It took us another whole day trying, believe it or not, to get the discharge CAT scans from the hospital. And it turned out he had a pancreatic mass that needed follow-up. So anyway, the efficiency and the time wasted, it's great on one side because I knew he got discharged. I graduated in '83, and I only knew when the patient got discharged when he showed up in my office, and sometimes it's 2 weeks later, and the readmission rate goes through the roof if you don't follow up with your patients within 7 days. The studies have all shown. So it's great that we knew he got discharged, but the type of information coming across is not always accurate. But it's been helping us a lot in our follow-ups on most of our patients going forward.
So Tarek, just to be clear, you spent how many hours going through a 70-page discharge summary?
And believe me, I hate it when it's on your computer because you got to go from page to page. I'd rather print it out and read through it. A little old-fashioned in that case, but it took a while.
A while. Yeah, I mean, one big takeaway here is we have a lot of information, usable data at the right time in the right place. That's the challenge of data exchange, right? So, Julia, I wonder if you describe the system you built to manage the patients that are in your high-risk program.
Thank you, and
Welcome.
thank you for having me here. I'm honored. I came 6 years ago to the organization, and they had about 20,000 lives under capitation, dual risk between the IPA medical group and the hospital. And one fund, there were 2 groups, and one fund was chronically upside down, and the other one was breaking even, making a small profit. But nobody could tell me why one was doing one thing and one was doing the other, except for the proverbial, "My patients are sicker." these patients are all sick. They're 100% Medi-Cal patients. And they told me, I said, well, what's my job? They said, grow the business. So I said, grow the business? I can grow the business. So we wrote a business plan, and I told them that I don't think we could grow the business and take financial risk if we didn't have a population health division that had clinical support, psychosocial support, and systems that would allow us to understand how to keep the patients well, understand their chronic illnesses, and know how to advocate for themselves. And this is a great organization in that regard. They went for it, and now we have 135,000 patients under our management, and we have a chief medical director and a couple of social workers and 3 very skilled chronic care nurses and community health transition coaches and community health workers, all with lived experience. It's a requirement to work in this division to have lived experience because you're going to see some tough cases, and I need to know you've been there and you know how to handle it. And so that brought us the toughest cases in Los Angeles County into our hospital. And the goal was not just to keep them out of the hospital, to keep them well and understand their chronic illness. And that's the journey we began on. We kind of built the plane as we were flying it. So we signed up for the health information exchanges and started working with both Manifest and Lanes. And we started hiring the staff, and we started doing workflows and algorithms and working with the physicians and the IPA to come up with a plan to have hospitalists follow the patients, to have daily rounds where they debrief with us. We have morning huddles where we talk about all the patients that came in each night. So it's a whole access point. We're looking at who came in, who stayed out, who's at some other hospital, and how are we going to manage them.
So you mentioned Lanes. You might explain for the folks in this room what that is in terms of the system itself that provides you with the data that you need to manage this population.
Sure. Lanes is a health information exchange like Manifest. We ingest our data from the hospital every night into their system, and they are participating with a lot of the hospitals in Southern California, some of the medical groups as well, and some of the health plans and all of the pharmacies, which immediately gave our emergency room physicians access to information they never had before. So if someone comes into the hospital emergency room each night for 4 nights, you can see, are they seeking drugs because they've been getting pharmacy prescriptions from other hospitals in town? You can see, do they have a support system in place? Are they unhoused? There's a ton of information in there, and each hospital is at a different pivotal point in their relationship with Lanes because they're also growing their organization as they're flying it. And so sometimes there's a lot of information, sometimes there's little information. So it's a lot of digging still.
Great. So we're in Sacramento, and in this room are a number of folks that have influence on policy and think about policies. I wonder, maybe I'll start with you, Julia, what recommendation would you have for California at this moment to take the momentum that we have in data exchange to scale what we've learned to really accelerate the work that's going on? I wonder if you have, what would you advise this audience in that regard?
Yeah, absolutely. I mean, I do think we have a large amount of infrastructure that can be used, and so a key piece of it is incentivizing use of that infrastructure. And so I think, in Julia's case, right, they have a strong financial incentive to use Lanes and Manifest, and we should make it easier, but even with the friction, it's still worth it because of the information that's able to be garnered. So I think we really have to think about mechanisms to align the financial incentives to make best use, even as we're continuing to improve the infrastructure and the workflow integration.
Tarek, you have recommendations for this group?
I think, going back, I think in healthcare, we serve a large Medicaid population in Inland Empire. And as a physician, 20% of patients' healthcare depends on me, on our group. 80% of patients' health depends on their psychosocial determinants of health. Where they live, we all know that zip code defines how long you're going to live. Housing, whether they're living in one room, as we find out. And these are questions we don't get. So getting information on the psychosocial determinants of health of our patients so that when they show up in our clinics, we know exactly that this is a single mom who lives in a one-room apartment that has a $1,000 income and renting a room for $600 and has 3 kids. I mean, we cannot manage that patient's medical care unless we are able to know that information and be able then to act on it using the community health workers and going forward. And then the other thing I would always say is trying to standardize the information we're getting from the the HIEs. We get 70 pages. I only need a summary of what really happened in the hospital and who the hospitalist was, which is another challenge, trying to figure out who took care of the patient to call him up.
So just to name, financial incentives, Tarek, partly what you're saying is a workforce that leverages folks that are not just MDs, but community health workers, social workers, this whole notion of how do we get to the social determinants of health and how do we get that information?
Absolutely. I think, and I know there's quite a few medical students here, which I'm happy. It's really, we're very reactive in the way we take care of our patients as physicians. And we really need to be more proactive when we're dealing with our patients, knowing who our patients are and reaching out to them before they show up in your offices. Yeah.
Let me ask maybe all three of you, are there things that you would say if we could move this one thing quicker, we could realize the benefit of data exchange in real time? Is there anything that, I don't believe in magic wands. There are no such thing as magic wands, but how do you think about sort of where the log jams are? We clearly, this panel, Scott, have all named what the value is to patients, to outcomes, to quality. What makes the momentum for scaling this statewide hard? What would you name? Julia, maybe I start with you.
Sure. I tend not to be a technology evangelist, but I have to say, as we are starting to experiment with the ability of generative AI to effectively summarize vast troves of medical information, it is pretty impressive. And so my hope is that we're going to be able to sort of break out of this brittle era where we're trying to standardize records and harmonize them. And the task is just too big. And I think we have to pretty rapidly shift to using, new generative AI tools to be able, so a doctor could just patients coming back from the hospital, this is the concern, summarize for me what's relevant from this hospital stay, and you just get that nice crisp summary. I think that is really feasible today, but it will take a shift in approach in terms of how we've thought about the technical underpinnings of how we're approaching HIE.
So, Bravo, can I do a follow-up? You've written a lot of literature, you reviewed the literature, you've seen where data exchange is working. Is there anybody in the country that's in this space starting to use generative AI and starting to really kind of leapfrog where we are in the current technologies?
Yeah, we just finished our national HIE survey, and so we asked the country's sort of 100-ish exchanges like Lanes and Manifest, where are you with AI? And we were actually quite surprised that many of them are already using and integrating these tools. So I think that everyone is seeing the new opportunity here. And as much as I hate to say it, I think our electronic health record vendors are also working on these capabilities. And so, if you look at some of the tools that Epic and Cerner and others are putting out, they're quickly integrating generative AI to do chart summarization. So I think we'll see it in many different places. And I think, again, we just have to make sure that it doesn't get too fragmented where you have to go one place to get one summary and another place to go to another summary. So that's the piece to try to think about from a policy perspective.
Fair enough. Tarek, anything what would you name? I
think one of the things that will help efficiencies would be what we would consider as a single sign-on. In the Inland Empire, we probably have close to 1.7 million Medicaid patients, and 75% are managed by solo and small group practices. They cannot afford the ability to be able to log in, to manifest, try to get the information, and then go back into their EMR. So a single sign-on would be where they would log into the patient's EMR and they would see a pop-up that says, patient was in the hospital yesterday. That way, I think, would improve the utilization for the majority of small group practices.
So single sign-on would be what you would say?
Single
Julia?
sign-on.
Beautiful. Julia?
I would agree with a single sign-on, especially in the emergency department. The ED is packed. It's a 12-hour wait in most every emergency room to be treated or even triaged. And toggling back and forth between all these systems is a nightmare for the physician and the support staff. So that would be one. The other I would be really excited about is if we could take away the financial barriers that small practices face, that small hospitals face, and other entities like CBOs to, community-based organizations that are providing a lot of the ECM services. If we could take away the barriers so we could get bi-directional feeds in every one of those organizations, that tool will become a robust machine that really, coupled with AI, it'll really be able to help people get in, get out, and point the right person or support system in place for them to keep them getting their care at the right place at the right time.
So I want to pivot a little bit to this concept of trust and consumers. I know HCI spends a lot of time making sure that data is secure. How do the three of you think about data security and how we use that data in order to make sure that we don't lose the public's trust as we move to continue to expand the use of interoperability and data platforms?
I can take
Julie, you
that.
want to start?
It was one of the biggest obstacles we had to go through and convince our leadership team that if we were letting our EHR data out of our domain, how was it going to be secure? That transfer from one entity to the other, and then once it got to that entity, how were we certain that they were going to trust it with the same amount of trust we put in it? And then how would we explain it to the patient? Because that's another whole 45-minute conversation with each patient on how they had to give permission for us to upload that data. And we did query a lot of the bigger systems that had already put the HIE in place and had the bi-directional feed, and we found that most of them were using a negative acceptance in the admission process. And we took that route as well, and we also gave them an opportunity to opt out at any time, so they can opt out at any time. So that's been a big help for us.
Great. Derek?
From a perspective, from the patient's perspective, I don't find much problems with the patients. We let them know when we call them the next day that we got information on the HIE and that we got discharged. They're very happy about it. I think with Manifest, it's a automatic opt-in, so they have to opt out if they don't want that information, which also helps a lot. They sign a consent form when they come in. We have had probably no patient really that opt out from joining Manifest. Yeah.
And you're on the board at Inland Empire Health IE, so how does the governing board think about data security?
We're under the umbrella of Manifest, so we feel comfortable. I don't think there's any issues with that. I think data security is dependent. It's a big problem, I think. When we first started our HIE, it must have been about 10 years ago, there was a lot of concern about who had the data. Hospitals did not want to share data with us, and they felt that it would give them other hospitals advantages over them, but that's all been overcome, I think. Yeah.
Don't you think we're over the hump with hospitals saying
Yeah,
we've...
I think from our understanding, I think every hospital in the Inland Empire, which includes Riverside and San Bernardino, is hooked up with
on board? Great. Joy?
Yeah, I mean, I think health data security is just sort of table stakes for any healthcare stakeholder at this point, right? Every hospital is invested in it, every HIE has invested in it, and I think I worry much more about the loss of public trust when we don't get the information to the right place at the right time and something bad happens. So I think it's sort of two competing trust frameworks, and I do think we are at the point where, as you said, anyone who's seen firsthand what this looks like would say, I just want my information to get there. And they just assume that we're going to do that safely and securely. So I do think I always think of that as the framework to move forward with, is we have to do what's right for the patient. And I think a piece of this too is we also have to take advantage of asking patients, are we doing this well for you? And people often ask me what, if you could tie incentives to something, what would it be? And I would say, well, we should have a Press Ganey question or some way for patients to say, did my information get there to provide the best care for me? And that's what we should be holding our healthcare system accountable for. And so I do think there's some sort of low-hanging fruit, and California could be on the cutting edge of thinking about how to do that, because patients see this firsthand, and I really do think it erodes trust in our healthcare delivery system.
Are you seeing that being applied anywhere else in the country as you do the work that you do nationally and as you review the literature? Is there anybody actually beginning to measure trust in that way?
I mean, there's research out there that asks on sort of patient perceptions of data sharing. And again, by and large, I think what you do see is yes, they want their data protected, but they also want it to be shared. And so it's the same dichotomy. And so I do think that where there is data, it tells us that we should keep doing this work because it's in the best interest of the patients. And there are not that many examples of information getting into the wrong hands and being used for bad purposes. I will say that the Dobbs decision put a huge chill on our information sharing, and I think we have to name that, because as patients are traveling to California to get reproductive care, we have to think about extra protections, and that led to a whole discussion about data segmentation. Can we actually pull reproductive healthcare information out of medical records before we share it? It's probably a conversation for another day, but I mean, this, again, it continues to be a complex space, even when the North Star is what's best for the patient.
We've talked, did you want to ask something?
One of the things I'd like to add too is when we started taking the risk for large groups of people, that whole issue of discharge summaries became a huge emphasis, because it was the really first time people heard large masses of doctors saying, I'm not getting a discharge summary that's worth anything. And so we put them all in a room and said, develop us one. And our hospitalists use it, and it's in the record. And when our community health workers accompany the patients to their first visit with their doctor after they go home from the hospital, they bring their laptop in case the doctor has not received it. And it gets it right in front of the doctor, and it's a very simplified summary, and it pulls all the key lab and x-ray elements, the beginning and the end of the story, and the next steps. And that's been huge for us. That is something we need to be able to have something like that in the HIE, which doesn't exist right now. There just doesn't seem, at least in lanes, which we use the most because they have the most LA County Medicaid patients, there's not a good summary function. It's a lot of disparate data uploaded into it.
Derek, do you want to add something?
Yeah, I just wanted to add probably just one of the things we don't get on our HIE is all the behavioral health and psychiatric discharges and medications. There seems to be a wall between the medical and the behavioral health. We started integrating our behavioral health into our own clinic, so this way we are able to communicate directly with our behavioral health specialists. But I think it's critical that this information gets to the primary care physicians in the community so they know what's going on.
Yeah, thank you for going there. That was actually where I was going to go next, which is we have a very fragmented way that we approach behavioral health in the state of California. another area for another day that CHF does some work in. As we've done the signatories for the framework, counties don't really have the resources, or at least they'll say they don't, and largely probably true. And so I'm curious, I mean, Tarek, you mentioned this, the behavioral health carve-out with counties doing serious mental illness care. How have you, Julia, if you have anything you want to add here as well, how have you integrated the county piece of the behavioral health work floor?
It is bifurcated for sure. It's really difficult to get the county information at the community level. And if you think about a patient from the moment they're born, their health record begins, their health story begins. And people move, they change physicians, they change insurances, and each one of those are a break in their history. And if we don't have a way that we can see, and if we don't look at the three real issues, the medical, the social, and the behavioral, we don't have the whole story. And we can't treat the whole patient without the whole story. And for the county to hold on to the information, we understand that there's mental health laws and protections, but a lot of the patients who come into the emergency department are not medical patients. They're presenting as medical patients because they have medical problems that may be self-created, but they're behavioral underlying.
Julia, you want to add anything on this?
No, I mean, I think, we do have a regulatory framework that separates that data, and I think it's just this Achilles heel where there are good reasons why that regulation exists, but we also see how problematic it is when you're trying to deliver the best care, and so it's a tough nut to crack, especially because, again, even when you try to say, well, could we just give part of the information, the part that's least sensitive, it's not clear if you're doing more harm than good.
A statement to our fragmented delivery system. Okay, I want to take a moment and be able to open it up to anybody in the audience that has any questions for the panel. There's mics going around, so feel free to raise your hands if anybody's sitting on anything or if there's an issue we haven't raised. Yeah, right behind you, Melissa. Please introduce yourself.
Yeah, stand up. Good afternoon. I'm Anna Sutton. I'm actually at CMQCC, the state's perinatal quality care collaborative. I'm the project lead for the HRSA Maternal Health Innovation Grant. This is an incredible presentation. I'm actually curious, are any of the health plans, Medi-Cal health plans, using health information exchange to enhance any of their new CalAIM benefits like transitional care, as well as enhanced care management?
Tarek, do you know? Medi-Cal plan, Inland Empire Health Plan?
Well, I know we're with the Inland Empire Health Plan, IHP, and I'm pretty sure they're using, because they're part of the manifest. So they were part of starting up the HIE and the manifest. So I know they are getting information from there, yeah.
Julia in LA?
And in Southern California, there's a high preponderance of dual risk patients that they're capitated, so a system is taking care of them on a more close-knit basis than the health plan is. But I know LA Care is using it too, and so that's helpful. And they're also starting to let loose of some of the reins that they've held so close on the ECM and CBO stuff. So we're getting a little bit closer to the patient to help them in those areas too, taking out some of the layers that have been sort of obstacles.
Maybe I'll just note that CHCF supported our ability to survey the managed care plans to ask them about their HIE integration, and I'd say they're actually some of the leaders in terms of what they say they're doing with using HIE capabilities. So I do think they're using it, but understanding exactly the use cases, I think, has been harder to understand.
Hey there, Jim Hickman with the Camden Coalition and a couple other affiliations. I just wanted to answer that question. There's a number of small to medium-sized technology vendors who are providing that last mile connection for a lot of these health plans, Activate Care, many that the CHCF has funded in their own right. So I think sometimes in this conversation we forget there's an outside lane of innovation, often rooted in the private sector where they're doing a lot of good work. And I see Timmy over there, she's got a sandbox where sometimes they come and play in that sandbox. But if I had a policy recommendation, we need a sandbox that says, let's bring the best of what we have, AI tools and the like, and start testing for that last mile. That's what we're lacking.
So now I'll ask you the question, where would you build the sandbox?
Well, it's in the cloud.
Okay, there you go. Beautiful, okay. Yeah. Jim, do you want to
It's a
say something?
softball.
Please, introduce yourself.
Hi, everyone. Timmy Leslie. I'm the Executive Director of Connecting for Better Health, which is a coalition to advance data sharing. And this is just such an incredible and absolutely incredible discussion. And the focus on that last mile is exactly what we have really pinpointed as a place for our investment and our muscle. Because we have observed that we're really high talking about policy, and often we need specific use cases, and we need that use case to then drive better policy. So we have both the design studio taking organizations through to understand what that data sharing looks like in the real world, and then we can go test it in the sandbox. So 100% thank you for bringing that up in the conversation, but I think there are tools in the toolbox that we haven't had before, and it's time to kind of really lean in.
Julia, I think you did a paper or an overview on use cases. I wonder if you just sort of share some of the examples of use cases since that issue came up. Beyond the ones that we've touched on here, are there other use cases that are worth, if we're going to, in the sandbox that you would say are worth pursuing?
Yeah, I mean, there's so many use cases, which I think is part of the challenge in this space is, I think some of the really well-prescribed use cases like e-prescribing, right? Like we're pretty much doing that 100% electronically at this point because it was such a clear, well-prescribed use case with like a relatively small, some might argue a monopoly, in that space. And you can see that we can move really quickly when we have those conditions. But then I think you get into like care coordination. Is that a use case or is that 100 different use cases? And so that's where I think, we've had, I think ADT alerting is another example of like a use case that was specific enough that we were able to move quite quickly, build policies around it, and get infrastructure in place. But this sort of, getting all the information that you might need to an ED provider at the point of care, that's a bit of a broader use case that's more challenging, or the payer use cases. So I think we're not short on use cases. It's really a question of prioritization and how specific we are about sort of what the end state is for that use case, and then the stakeholders and the incentives that need to go behind it.
I mean, given that, this will sound like a wild understatement, but given that we're in a resource-constrained environment, and increasingly so, and the state has very bold goals around how to make healthcare more affordable. In the use cases, are there some that would help us get it affordability more directly, in your mind?
Yeah, I mean, I think that's where all the use cases related to hospitalizations and avoiding readmissions are probably at the top of the list. And I think we've already heard some examples of, not just an ADT notification, but enough information that the community-based provider can very quickly intervene and make sure that the patient is stabilized to reduce the likelihood of a readmission. And the same thing, I think, really focusing on the ED. What is the information that team needs to understand if someone needs to be hospitalized or not? And even ideally bringing in the community provider as part of that decision, which I think, it's another part of my hope is that this isn't just about information exchange, but it's about team-based care and care coordination among the team that knows the patient best. And so can we think not just about moving the information, but actually starting to have tools that bring the care team together in a more coordinated way?
Can I add
Yes,
just
please.
a little bit also
Sure.
on the health plan integration? It's not just affordability, but it's also concerning the quality. As primary care groups, we have got to report our quality, and so we're in the final stages of our bidirectional connection with the health plan through the HIE, so that the flow is going back and forth between the health plan and our system. So given examples, patient might have had a mammogram done somewhere else. We never get that information, but the health plan gets it. We're able now to get it and populate it into our population health platform, then which improves our quality data going forward. So quality plays a big importance on the HIEs.
Can I just say too that I think when we talk about cost too, I mean, there's the cost of healthcare, but then there's all the opportunities for administrative efficiencies. And I think if we could really invest in good health information exchange, there's a huge amount of administrative efficiency to be realized in the system, which hopefully would then trickle down to affordability. But those are, I'd say, two distinct but equally promising pathways.
Well, and we have heard from numerous surveys, some that CHCF and others have sponsored across the state, that administrative redundancy is also where there's a lot of friction for patients to try to navigate. And so both to extract the administrative inefficiencies, but to the extent that we can also make it simpler for people to navigate our delivery system, those would be a win-win, I think we'd argued. We get some waste out of the system that doesn't help us get better quality or better outcomes, and make the system easier of use for our patients, and particularly for patients who have limited time, stretched resources, et cetera. So a really important point. Other questions or comments? Melissa, you nudging somebody there?
No, maybe I'm nudging.
So the question was raised about innovation and the role of the private sector here, and some of these companies that are trying to make these connections happen. And I'm not talking now about the HIEs per se, but companies that are really trying to improve the plumbing, for lack of a better way to describe it. Any observations on how we continue to make sure that engine provides this useful connectivity, as opposed to just more options on vendors? Tarek, I'm sure you have vendors coming talking to you all the time.
Well, yesterday we had our CMA meeting up here in Sacramento, and we had a section on AI. And one of the presenters actually said within a year, AI will be managing a whole hospital. The technology is just jumping through the hoops going forward. So I think AI is going to play a really big role in the future and going forward on that.
We actually are looking at options for us for AI to be able to reach out to our patients. A lot of people have call dialers and they don't pick up their phone, or they don't have a phone anymore, or whatever. But some way to use AI to get in touch with the patients, because this is the elephant in the room, finding the patient. And you want to prevent readmission, which we're doing, and these are big dollars when you get somebody in the emergency room that gets admitted because nobody knows what to do with them. And so trying to prospectively prevent that by building a relationship where they trust you and they'll reach out to you. This last Thursday, we had one of my community health workers got a phone call, and he was calling back her. She was checking in on his blood pressure and how was he doing on his new meds. And he said, I can't talk about my blood pressure today. I have no food and I don't get any money for 7 more days. So at that moment, she realized there was going to be no conversation about his blood pressure. It was probably elevated. And she said, I'm going to call you back, I promise. And she got on the phone and she found a charity that could bring over a box of fresh vegetables and fruit, and another organization that brought some day-old bread and some meat and things, and some salt, low sodium food. And he was so grateful. He said, nobody reacted like you did. The health plan has to push this button, that button. Nobody ever really talks to me. You get a machine, you get a voicemail. You really did that. How did you make that happen? And she said, because I wanted you to have healthy food over the weekend. And he said, okay, can we talk about my blood pressure now? So those kind of things I think are super important. I mean, there is a human connection that AI won't be able to replace.
Yes, please.
Good afternoon. My name is Carolina Arroyo. I'm with Health Project Center. I come from a long time of being in the primary medical care. Thank you for mentioning that, gentlemen. One of the things that I've myself seen is a provider addresses healthcare. But when you have somebody, an indigent person that has no housing, no food, they come back, they have an A1C of 12.5. Doctor is like, you need to start taking your medication, but they forget to ask, why haven't you taken your medication? A lot of the times this patient doesn't have a refrigerator to keep their insulin, and they don't pick it up because they know they're not gonna have that. My point is, this information is not being shared with providers. If the provider doesn't have that patient is unhoused, or if the provider doesn't have that the patient doesn't have transportation, how are they able to help that patient? So my question with talking about the data exchange, how are we looking at data exchange with case management, ECM, and all of those support services that are being given to all of those patients at the time?
Yeah, I mean, you're raising the social determinants of health, and Tarek, I know is something you and your practice have thought a lot about. You know, we were all trained to start with asking a patient at the very outset how they were and what they were there for. And so if you're just looking at labs and just looking at hemoglobin A1Cs, you're going to miss the fact that actually housing is their health issue. And so, Tarek, I know your team has spent a lot of time sort of building out this capability. And I think your point is that AI won't necessarily extract that. Some human being is going to have to extract that information, then get it in the right place so people can act on it. But Tarek, you've done a lot of work in this space.
Right, and we have over 1,100 patients on our ECM teams, and they're out there. We have about 200 on our...
We've been talking about ECM, just so for the rare person that doesn't know what ECM is.
It's an enhanced care management program that was rolled out by CalAID for the state, and we've got about 220 homeless patients on this program. In our clinic, we've implemented Prepare, which is collecting all this data, and that is a very time-consuming program. I mean, it's really, if we collect this data once, it'd be nice then to share it with the HIE so we don't have to keep asking these 5 domain questions on our patients. So I think that's important from a HIE perspective for that data to be captured once. You know, I always joke, you go into Nordstrom and pull out your credit card and they know exactly where you eat and where you sleep and what you do for hobbies, you know. It's scary. And yet when you have a patient going to the lab, they have to fill out forms. They go to the specialist, they have to fill out forms. I mean, it's really, we're living in the 19th century still.
Yeah. Yes, please.
Hi, Julie Silas from Home Base. We're a nonprofit working on health and homelessness. And we are partnering right now with Blue Path and Connecting for Better Health and Georgetown Massive Data Institute to do some actual community practice between the managed care plans and the homeless systems of care to do data matching because they don't even know what shared clients they have, and then also keeping a lot of the data encrypted but sharing small pieces of information to be able to know who's their case manager in the homeless system of care. So if we can't find them, we know who might know what food bank they go to or what soup kitchen they're at. Or for the homeless system of care to know, oh, this person is actually receiving enhanced care management and here's their provider, you might want to connect with them. And so we're starting to do this now. We're in beta testing right now, working with a couple of partners, but we hope to roll this out in the fall with a number of partners across the state to try and test and make this work so that we're not at a place where, at least for people experiencing homelessness and people with high vulnerability chronic conditions, they can do some matching and sharing.
Maybe just a quick note on that. I mean, I think health information exchange works once you know where someone has gotten care and where their information exists. But there's really a first order issue of just like who is interacting with this individual for what purpose. And so, I think, if we could just solve that piece where there would be a way to understand, who is doing what for that patient without even all of the hundreds of pages behind it, like that would be a huge part of the solution. And so I think there are ways to start with maybe simpler pieces. And so I hope that your demonstration will show us the way for that.
I can speak to that a little as well. We're working with Lanes on that as well. We did a pilot project in one of our emergency rooms where we gave every single patient, whether they were one of our capitated patients or not, an SDOH, Social Determinants of Health survey, and we told the hospital that we would take all of the surveys, if they would scan them in and upload them to us, we would do the follow-up, we would score it, and we would have somebody call them. And then one day I got a call from my population health manager, and she goes, "Did you really agree to that? Because do you know how many we have?" And it was about 80% of our patients were one paycheck away from not having a house. So it really made a big difference. But what we did was we uploaded all that information into the electronic health record. Then it got uploaded into Lanes when we did the feed. So now that data's in, but it's dynamic. You know, you could be housed today, and 2 weeks from now you could not be. So it's not who's asking it besides us.
Melissa, can you get him a mic, please?
Sam Griffith from Health Project Center, a CBO in Monterey County. Got a question. We're talking about HIE a lot of the times, but there's also other systems like the Homeless Management Tracking System that tracks individuals when they're at that cusp of being homeless or at homeless. And a lot of information with the CHWs get uploaded into that. Is there going to be a way to connect that information? Because a lot of times in the ECM world or the counseling world, we're always trying to track down individuals, and that's one of our biggest struggles. So is there a way to make that interoperability really happen between these other systems that are tracking individuals?
Terry, your thoughts on that? Terry?
Well, I don't know if I want to talk about that, but you know, the data for every patient on Medicaid has to fill out an application. That data exists in this world. I mean, the data of their income, and if we can just grab that information, that would be great, but that's another political.
Scott took note of that.
That's a whole different.
He's got a sister organization. He's part of a big department, and you know, I mean, to be fair, and Scott, if you want to add anything, feel free. But I know the agency itself is trying to work on how do we take the information that, as Tarek says, is fed to the health plans, to the state. How do we make sure that that information is actionable? So I think that's what you're getting at, Tarek. Yeah, fair enough.
Yeah, I think the data. I think the key here is how can we be more efficient as a healthcare system? You know, the data is out there. We just have to be more efficient in how we practice medicine.
And asking the health plan and getting told we don't have it, we don't know how to get it, or you can't have it is not the answer.
Tim, you want to comment on that? I could tell. Yeah, please.
Well, yes, there's a lot going on in merging HMIS systems with the health plans, number one, and the HIEs. So that's the community of practice that's just joining or just starting up, so we can follow up on that. But it's definitely an area that needs to be uncracked. And I absolutely love the comment of health plans can't say no, and just broadly, counties, states, like how do we work on this together? And we all have something to give and get. But I'd love to go back to, it's one of the first panels I've heard of really creating better accountability across all of the stakeholders through either a quality measure, or there's now renewed interest at the federal level with information blocking, which I welcome. But where can we really drive us as patients and stakeholders and consumers better acceptance and better data sharing, I guess is the question.
You're sort of asking, is there a parsimonious sort of metric or metrics that you think would wrap all this together? Is that what you're asking, Timmy?
The magic wand of a quality measure, or information blocking. I think having more transparency around who's a good steward and who's not.
Julia, you want to comment on information blocking?
So let's see. I mean, I think there are fervent opinions on whether information blocking is a thing or not. And I think the problem is we don't have a way to separate when an organization is willing but doesn't have the technical or financial resources from when they're not willing, when they're have the ability to but are saying no and trying to obfuscate the reason why. And it's just been really hard to figure out a policy infrastructure that can cleanly separate those two instances and then go after and so I think, information blocking just as a concept was helpful because it allowed us to name that behavior, but the ability to then enforce it has been really challenging. And so, I think there are financial penalties out there that exist, and we should lean into what's there. But my general sense is that there's still a lot of willingness out there to do data exchange, and so we should sort of, where there is willingness, lean in there to start, and just try to give them some of the technical support and resources to at least get data exchange there, and then at the same time, try to go after the ones who are really being difficult. And that's where, again, I feel like if we could have more transparency and consumer reporting, that we have a whole framework for that. We just haven't brought it to the HIE space. We should have consumers reporting on their experiences with this.
I mean, lest we think that we haven't made progress, I mean, I remember being at a data exchange conference that Timmy's group put on when we were talking about the hospitals not wanting to share data. And so I think we've made big progress in the, yes, of course, let me figure out how to get you this data. We clearly have more work to do, but just to know we have made significant progress where, I built this EHR, it's my data, I'm not going to share it with you, or my lawyer tells you me not to share it. And so we've made progress, and I think the theme here is how do we get to yes? And use all the places that data comes in as efficiently as possible. So, Jim, I know you wanted to get in.
Yeah, first of all, that's absolutely right. We've come a long ways, and I think this connects to something both you, Dr. Hernandez, and Dr. Milstein have said. There's an individual context that is really important to understanding all these data connections. And 10 years ago, when Camden first came to Oakland and started working with me at Altabate Summit Medical Center, we did a simple N-of-1 case study. We took one individual, frequent utilizer of multiple emergency departments just in Oakland, and mapped all of her connections. 14 private-public interactions. And then we called a meeting, which was about $1 million meeting when you brought all those agency heads in. And at the end of the day, what was not in the EHR was the fact that she had a dog. And then anytime we referred her to some sort of support system, if they didn't take animals, she would wisely choose not to do it. So I still think no matter what we technologize, and I'm an evangelist for technology, there's that human connection and knowing that individual that is never going to leave us with AI or not. So I applaud all the work we're doing here with technology, but I think our most important workforce that's not in this room are probably our CHWs who are closest to those individuals in the community. And now a plug for a CHCF investment. You did fund an organization called PearSuite, and I would ask you to look at organizations like that who are building that bottom-up connection and retaining that information about that individual in that ecosystem, who are still struggling to connect into these broader conversations. So, sorry, Melissa.
What'd you say? Sorry. No. I mean, it's always good to come to these things and find new work for CHCF to do, so I do appreciate that, Jim. Any other questions? Yeah, go ahead. Please.
Hi, thanks, Lori Hack. Here today with my hat from the Mark Twain Healthcare District Board. We're a small healthcare district in Calaveras County. I'm so excited. I mean, I've known all of you for many years, and the innovation and the progress is amazing. But having lived in Calaveras County for the past 9 months now, I just wonder what's the plan for rural communities in California, because we're lagging really far behind.
It's a super important question. I suspect that LA and Riverside won't be able to address that. Although, Tarek, if you've got any thoughts on this, those are two really big counties, and not all of them are central in big urban centers. So any thoughts on that?
Definitely a problem. I mean, if you look at San Bernardino and Riverside County, it's bigger than most states in the United States. Distances between patients, sometimes some of our nurses spend a whole day just seeing 3 patients, just traveling across the county, you know, so that is a big problem, yeah.
It's similar in Los Angeles. They spend the whole day seeing 3 patients because they're sitting on the 405.
Yeah, I mean, I think we should stipulate that we do a lot of rural Californians for whom we don't have great workforce. There are physician deserts. We're increasingly seeing maternity ward deserts. You know, we're a very big state. We tend to solve problems around big plans. And some of our health plans in the rural north have done a great job in this space, but I appreciate you naming it and us giving some thought to it, and I'm sure HCI will also want to do that. They do a great job of making sure they look at the whole state, and we try to extract important information from all around the state and really think about creative solutions to exactly what you raised, so I really appreciate your question. So I have one more question, if nobody has one, because my background wouldn't let me do this without asking the public health question. We've just come off a big pandemic. I think we would all agree that we learned a lot of things, including what data we didn't have that we would have wanted to have. As we think about all these systems, worked in DPH, the public health connection to population health, to health plans, and how much data they have or might ought to have. It's a use case. I suspect, Julia, you've probably seen this as well. I wonder if the 3 of you would just, any final thoughts on how important it is to connect to county public health and state public health and how that data is useful. Julia, in the literature, any comments?
Yeah, I mean, in our last national HIE survey, we had a whole new section on public health connectivity, and I really do think the pandemic was an opportunity for HIEs to shine, because all of a sudden people saw anew, like, oh, well, these are the people who are putting together data-rich profiles of communities and able to, pull in test result data and not just report it at an individual level, but to look, by different geographies. So we saw, I think, a pretty good set of capabilities around public health connectivity, and we actually just collected our next round of data, and I think the question is, did we stall out or not? Because a lot of the funding the public health agencies got to improve HIE was short-lived around the pandemic and went away pretty quickly. So I think we're all worried that we're going to stagnate from here. And so yes, we'll be a little more ready if, God forbid, we have another pandemic, but it's just our continual problem if we just are so reactive and short-term in terms of how we make these investments. And so I'm worried that we haven't really invested in that connectivity to equip ourselves for the long term and really learn the lessons from the COVID pandemic for what we need to be ready for something in the future.
Tarek, any takeaways from the pandemic? Any lessons?
Well, I think just going back to the health department, I think they're critical. I think they need to play a key role in the population health of our community. We take care of 20,000 patients in our little environment, but to improve the health of our community, the health department has to know exactly where the poverty areas are across the community, where they need to invest more money, and we don't have that information. It's just a hit and miss going forward. So I think the health department should play a real big role in the health of the whole community, and they should get a lot of information from the HIE feeding into it, especially the psychosocial determinants of health.
Julia, briefly, anything you'd add?
I could agree more. It's just so important that they've got the information that we have it too. We shouldn't have to have 2 people going through all of our files to find our homeless patients. They know who they are. Share, please. Take down that barrier.
Well, we're coming to the end of the program. I want to just summarize a few key takeaways, perhaps. One is one that I think everybody talked about here, which is that Data Exchange has many technical capabilities, and it has many accelerants in terms of AI and the potential for AI's utility. But fundamentally, whether it's CalAIM or ECM or our interface for behavioral health. Data exchange is really a very important lever for us to get done, and actually to get done soon, because the better the data is, the easier it is to use, the more helpful it will be to the state as we take on the next big challenge. How are we going to keep people enrolled? How are we going to do eligibility every 6 months? How are we going to do workforce requirements? I mean, we have many challenges that await us. And so I hope the takeaway here is, yes, there's a lot of technical things. We've made a tremendous amount of progress, and we need to hurry up and get to yes in places that we haven't yet. So with that, if I could ask the audience to please thank Scott, our panelists, for their work, for their traveling here today, and for your insights. So thank you very much. There is in your packet, Danny has up a yellow page. It is an evaluation that helps CHCF and our team figure out what we did well and areas that we might improve. So before you leave, if you would take a moment to fill that out, we would very much appreciate it. Thank you all for being here today. Appreciate it.